Nice.
Wonderful. Thank you, Sue, for that introduction, and good evening, everybody. Welcome. I'm excited to be speaking with all of you. I want you to know that this presentation was put together specifically for the Billings teacher and other NFP method teachers. Hopefully there's some of you out there. We extended an invitation. So if you're on, thank you for coming and welcome. But I'm going to be sharing an inside look at what the IVF experience is like for the patient and also the provider. And I'm going to compare statistics between the success of IVF and the success of restorative reproductive methods. I'm going to share some new data, but also some unpublished data. And we will be sharing all of this with the attendees after the talk. There'll be links, there'll be some PDFs, and there'll be an opportunity for all of you to participate in a discussion over the next few weeks on some of the subject matter that will be presented today. So please feel free to put your questions in either the question answer function or the chat function, and then I will plan on answering those questions at the end of the talk. Also, I'm going to be sharing my screen with you here in a minute. While I'm sharing my screen, I'm going to go off of video, and then I'll return when it is time for me to answer questions or we start to have a discussion. So I hope you enjoy this talk, and I'm going to share my screen with you now, and let's get this rolling. All right, so the first thing is I want to share the objectives. Today, you're going to hear an example of how practicing morally illicit patient care can lead to a crisis of conscience. We're going to learn why assisted reproductive technology is a disordered approach to patient care. You're going to understand the top 5 serious issues with IVF and assisted reproductive technology so you can have productive conversations with clients or people that you know that are contemplating the use of assisted reproductive technology. And then we're going to reinforce why natural family planning and restorative reproductive medicine is a more effective therapeutic approach. So I don't want this talk to be about me, but I do want to share enough of my background so that you will find the information credible. IVF requires a team of people, and I functioned as a laboratory director and embryologist for about 8 years. So I had all the credentials, and I directed the hormone assay, the andrology lab, and the embryology lab for LSU Medical Center in Shreveport. But I also did the majority of the embryology procedures, including the one you see pictured here, which is called intracytoplasmic sperm injection, or ICSI, where the embryologist picks up a single sperm and injects it directly in the egg. We will be talking more about that later on in the talk. So what is this process of IVF really like, and why did it lead to a crisis of conscience for me? It also leads to a crisis in many patients, and I know there are probably several other providers out there that are struggling with this today. But most importantly, what is the experience like for the patient? For the patient, it's like a roller coaster ride. With each step in the procedure comes either hope and excitement with good results and devastation when there is a bad outcome. And it's very stressful because people really have very little control over the outcome. The best way for me to present this or to illustrate it is to give you a specific example, a real life example of a couple who attended our program. This is a different story than I've shared in the past. because there are many, many stories of my time in the laboratory. So this was a couple in their late 30s, and they were diagnosed with unexplained infertility. They did a total of 4 IVF attempts in our program. The first attempt, they're very excited, of course. It's very common for the patients to feel empowered. They're taking a very active role in their treatment. But then each step of the procedure generates either a high or a low, depending on the outcome. For example, could be the number of follicles that are developing during the stimulation process, or how many eggs were collected and what was the appearance of those eggs. Could be how many of the eggs were fertilized, and then what do the embryos look like as they're developing. So there are many steps along the way. And in this particular case, the patients had a very good stimulation and the eggs looked very good as well. But on the following day after insemination, when we were checking for fertilization, the patients experienced a fertilization failure, complete fertilization failure. So there were no fertilized eggs, even though the man had normal semen analysis. So this was totally unexpected. So you can imagine the devastation that occurred at this point. The IVF procedure was over at that point. On the second attempt of IVF, we proceeded to ICSI, where we inject a sperm directly into the egg. Back at that time, it wasn't routine to use ICSI on every patient, only those that had male factor. But when they used ICSI this time, they did get fertilization, which was great. So the patients were on a high, but then the following several days, the embryos did not develop well. There was very poor embryo development. So it was appearing that the patients had probably very serious male factor. Not only was it leading to fertilization failure, but it was also leading to poor embryo development. Very likely, probably DNA fragmentation of the sperm. Nevertheless, we had 5 embryos. 5 embryos were transferred. And the patients received a positive HCG test. But then when they came for ultrasound, the implantation was not viable and the embryos resorbed. The third attempt they tried gave them the exact same outcome. So now they proceeded to the 4th attempt. This time, on the 4th attempt, they decided to have half of the eggs fertilized with the husband's sperm and half of the eggs fertilized with donor sperm. 2 embryos were then transferred from each biological father. The couple achieved a pregnancy and it went to term. Of course, without genetic testing, there was no way for them to know whether it was the donor or the husband that was the biological father. So in this particular example, you can see over a period of about 2 years or a little over 2 years, how there were highs and lows, hope and sadness. And in this particular situation, they do end up having a baby, which is wonderful. But then as a provider, a part of you wonders if this is really what was best for them. So that brings me to what is the experience like for the provider? For me, the whole process felt disordered, like we were creating more problems as we attempted to solve one. There are financial and emotional costs to the couple, but also a cost to our culture and our society, as I will point out. And to help explain these negative aspects of assisted reproductive technology more vividly, I've identified what I call the top 5 disordered consequences of assisted reproductive technology. The first one is multiple pregnancies. During my time, it was routine to transfer 3 to 5 embryos. And of course, sometimes more than 2 implantations would occur. It's usually okay and safe for a woman to carry twins, but when you start having 3, 4, or 5 implantations, it has serious potential health consequences to the mother and the children. And it comes at an enormous medical cost. In fact, during the late 80s, early 90s, many neonatal intensive care units were developed in the programs where there were IVF, in the hospital programs where they had an IVF program. It was kind of a package deal. If you had an IVF program, you needed to have a NICU. Also, multiple pregnancies resulted in the very heartbreaking process called selective reduction, where one or more of the fetuses would be injected with potassium chloride in order to have them resorb and leave 1 or 2 fetuses behind. Now, I'm happy to report that on the last statistics, this has largely been corrected. In 2018, 90% of the births were singletons, and almost the remaining 10% were twins. And I believe it's mostly because of restraint in the number of embryos that they're transferring. However, what we don't know, because it simply is not reported, is how many singleton pregnancies there are because of the process of selective reduction. There are no statistics kept on how often selective reduction is used. The next consequence is abandoned embryos. Now, most patients decide to have all of their eggs inseminated and then select 1 or 2 embryos for transfer. And most of the time they will freeze the remaining embryos, but some patients decide to discard them. So after they transfer 1 or 2, they discard the remaining embryos. In fact, there was a turning point in my career when the institution that I worked for and the doctor who was my boss insisted that carry out the wishes of a couple who wanted their embryos to be discarded. It created some conflict. It went to the ethics committee of the hospital, and ultimately they ruled in favor of doing what the patients wanted. And yes, it was the patient's decision, but I had to participate in it. I had to not take action to allow those embryos to die. It was a turning point, really, in my career. Now, based on the reported data, I've estimated that there are about 500,000 embryos created every year in the US. And there's also about 45,000 babies born every year, leaving about 200 or 300,000 embryos frozen every year. And all of the remaining embryos either die, get discarded, or are used for research. Even many of the embryos that are frozen are eventually abandoned and subject to the same fate of being discarded or used for research. Now, there's few organizations that are trying to do something about this, and you will get links to these organizations if you're not aware of them. There's an organization called Sacred Heart Guardians. They provide burial services for the embryo remains. And then Snowflake's organization offers adoption services for frozen embryos. However, there's still much debate, and the magisterium of the church has not made a ruling on the use of embryos, frozen embryos, for adoption. A couple links that I will be sending you have some very good discussions in them about this topic. Number 3 is risk to the health of the mother and the child. There's clear evidence that women who participate in IVF have a higher rate of gestational hypertension, preeclampsia, gestational diabetes, and preterm delivery. Now, most of this was due to the high incidence of multiple pregnancies. However, there's evidence for these even in singleton IVF pregnancies. There's also the process of hyperstimulation syndrome, or the illness hyperstimulation syndrome, that some women can get. It very frequently occurs in women who have PCOS, because IVF does not actually cure PCOS. So the same artifact, the same defect in ovarian development manifests itself in the stimulation process. And they can many times be having very robust numbers of follicles. In fact, it's very common for these patients to have 30, 40, and one time as many as 70 eggs collected from one woman at one time. And if hyperstimulation syndrome develops, it's because of fluid buildup, vasodilation, and capillary permeability. So the abdomen has a buildup of fluid. It causes pain, swelling. It can cause difficulties in breathing and urination, and it can lead to kidney failure. And a lot of times what will happen is the embryo transfer procedure will be canceled, and the woman will have to be hospitalized until she is well again. And then they will go through frozen embryo transfer. Health of the child. Even in singleton pregnancies, there is a higher incidence of low birth weight, preterm birth, congenital and neurodevelopmental orders. Now, most of the IVF children are perfectly normal. However, there is higher incidence. The other thing is we talked about ICSI. ICSI, there has been data to show that there may be an increased rate of autism in ICSI conceived children. And the talk is around epigenetic changes. So epigenetic changes are not changes to the genome, but changes in how the genome is expressed or activated. And they think it could be related to the stimulation procedure, or more likely due to the in vitro culture and manipulation process of the embryos, because no matter how much we learn, we're not anywhere near what embryo culture is like inside the uterus. And these epigenetic changes are resulting in increased rates of cardiometabolic disorders in the adults. So things like insulin resistance, high blood pressure, and higher body fat composition. Number 4 is legal and ethical challenges. Whenever you have multi-party reproduction and or frozen gametes and embryos, along with unstable families, divorce or separation, sometimes even death of a partner, you end up with very strange custody battles and moral dilemmas. In the links that I will be providing, I provided some information on the current court cases. And you just can't make some of this up, how the situation develops. I do, however, want to share some specific information for you in regards to this, information that will help you to have good conversations with clients, family members, and others you may know that are considering this. But secondarily, information that will help you be aware of the culture war that we are in. So I want to thank Alana Newman for providing this information for me. Alana is a teacher and a member of BOMA, and she shared this information with me. She's been a very outspoken critic of the use of donor insemination. She has a personal story that makes her very credible. But this report was published by the Institute for American Values in 2010. And they evaluated the well-being of young adults conceived through donor insemination. And you will have access to this PDF. So it's long, it's actually over 100 pages, but there's a lot of good information in it. There's just a couple things that I want to share with you about this. So first of all, you'll see that there are 3 types of problems that young adults can have. They can have problems with the law, they can have mental health problems, or they can have substance abuse problems. And in these groups, you'll see here the last bar graph represents children that were raised by their biological parents. And then they were compared to different types of donor-conceived children. Either donor-conceived children from lesbian mothers, by donor-conceived married heterosexual parents, or sperm donors conceived single mothers. And the bottom line is simply that the rate of these problems are much higher in donor-conceived children, especially substance abuse and problems with the law. Statistically different. And one more piece of information I'd like to share. Again, these are the three same problems: problems with the law, mental health problems, and substance abuse problems. The first column here are the rates of these problems in children that were raised by biological parents. And then the rest of these columns are either adopted or donor-conceived children that were informed about their conception in different ways. Basically, what the data shows is that when parents delay, which is this last column here, parents revealed the conception after the age of 13, or worse yet, they attempt to conceal the fact that they were conceived through donor conception and keep it a secret, the rates of these problems increase dramatically. You can see here mental health problems, 51% from children that were conceived by donor insemination and the parents attempted to keep it a secret. It's essentially not possible to keep something like this from your child for their entire life. It's very, very difficult. In fact, the biggest problem with donor and conceived individuals that they have is the fact that their biological father, or it could be a biological mother from oocyte donation, allowed for their conception. They did it for money, and then they chose to have nothing to do with them. This is a very, very difficult challenge for these children. The other thing I want to share with you again, so you're aware of the culture war that's out there. This is the American Society of Reproductive Medicine, one of the bulletins that they put out. It is the main medical society for all of mainstream reproductive health. They are very well funded and they're active legislatively. Here they're promoting awareness and financial support for fertility preservation. Now, when most people think of fertility preservation, it's easy to kind of understand it if you think about a young person in their reproductive years who is diagnosed with cancer, and the treatment is going to render them infertile, most likely. So the thought is that you could preserve their gametes, either the sperm or the eggs, and then use those later in life. However, the ASRM wants to extend fertility preservation to another group of individuals. This is a podcast. There was actually several podcasts that they put on in regards to this. And what they're trying to do is promote it for the use of transgender care. So before a person would go for gender transition, which surgery or hormonal treatment could render them infertile, they want to be able to offer fertility preservation. And this particular podcast was of a patient named Tristan Reese. And this is a picture of Tristan here. So Tristan was born a biological woman, but went through a transition to become a man, either some surgery and hormonal treatment. But with the aid of assisted reproductive technology, Tristan was able to get pregnant, as you can see here. Now, I'm showing you this again, not to promote hate or discrimination, but to just point out the agenda here. Because Tristan works for an organization that actively promotes assimilation of the transgender lifestyle. And their goal is not to just stop at their right to be able to do this. They want these procedures to be covered under medical, under normal medical care. And of course, the ASRM loves this idea. Their agenda is to be in all the schools. They want us to be trained on how to appropriately address them. And after training, if we don't do it, they want to be able to enforce this through legal or employment practices. So even though you may be at home homeschooling your children, we did ours, and they're not being exposed to this in the schools. When they get out into society, through the laws, through employment practice, and through insurance that they will be paying for, they will need to participate. And unfortunately, if the silent majority continues to be silent, this will happen. And finally, number 5 is human experimentation. I just mentioned 3 of them here. There, of course, will always be mavericks, and they're always going to be pushing the envelope. But and with the story of ICSI, this was widespread use throughout the field. So ICSI, intracytoplasmic sperm injection, was used in across all of the field before it was adequately tested in animals. And in fact, it was the success of humans that led to greater success in animal models such as mice and rabbits. So we have no idea really what the long-term consequences, and I've already mentioned the fact that there could be epigenetic changes that are resulting, increased rates in autism and other cardiometabolic disorders. Cytoplasmic transfer is the taking of a small amount of cytoplasm from a younger egg and transferring it to the egg of an older woman. And then germinal vesicle transfer is basically completely replacing the cytoplasm of an older woman's egg with the cytoplasm of a younger woman's egg. Now, there have been offspring produced through cytoplasmic transfer. I believe it's somewhere between 30 and 100 at this point. But germinal vesicle transfer, to my knowledge, has only been used experimentally, and any embryos that were produced were destroyed. But once again here, we do not know anything about the long-term consequences. You're essentially producing an individual from 3 people. So the genetic material still comes from the man and the woman, the father and the mother. However, the cytoplasm with mitochondrial DNA is also a part of that individual. So we don't know what the long-term consequences of that are. And then finally, CRISPR. CRISPR is an acronym for a method of genetically editing an organism. And there have already been born in China twin girls who had their embryos gene edited to make them resistant to HIV infection. Now that may seem like that's a noble cause, but once again, we don't know the long-term consequences, because sometimes when they do gene editing, they can actually edit non-targeted genes. So human experimentation is a serious issue. So now I'm going to move on to the second part of the talk. And most people believe that IVF is the modern science. It's the effective way to conceive. It's far more effective than natural methods. That's what people believe. But I want to explore that and compare it to natural family planning and restorative reproductive medicine. So these are statistics that are taken from the Society of Assisted Reproductive Technology. They do report statistics every year. This is for 2018. And you can see here on this axis, first you see the percent of live births per IVF attempt. And down here on this axis, you have the different groups: women less than 35, 35 to 37, 38 to 40, 41 to 42, and over 42 years of age. So you can see here that the live birth rate for IVF attempts in women that are less than 35 is almost 40%. And for the next group, 35 to 37, it's almost 30%. And then it drops off quite significantly the older the woman gets. Now this is looking at live births per new patient. So this would allow them to go through IVF or frozen embryo transfer multiple times, as many times as they want, essentially. And of course, if you try more often, you're more apt to get pregnant. And you can see here that the youngest group, better than 50%. And the group 35 to 37, greater than 40%. So we're talking almost one out of every two, or one out of every three, approximately, will have a live birth. Of course, once again, it drops off quite significantly based on the age of the woman. Now, this is some data that was published by Phil Boyle and colleagues. Many of these physicians are part of the International Institute of Restorative Reproductive Methods. They were using NAPRO and the Creighton model in this particular study. And you can see that it, again, is still live births. But these are patients that previously failed IVF. And so this is a very challenging group of patients. And the first thing I want to point out is you don't see that dramatic decrease like you do in the IVF data. It turns out that actually investigating the underlying cause and trying to treat the underlying cause is actually very effective for older patients. But of course, these statistics are a little bit lower. Here, the best group was 35 to 37. You can see close to 40% live birth rate. And that actually compares quite nicely to this same age group here, which was just barely over 40%. So even with these very challenging patients who have already failed IVF, the statistics are almost the same. Now, this is data that was published just last year by Marshall and colleagues from Womb in Australia. And I do want to point out that this is not apples to apples. So first of all, it is clinical pregnancy, not live birth rate. But also that these are infertile couples. So couples that have been attempting to get pregnant for 12 to 24 months, which is anything over 12 months of trying is considered infertile. The age groups are a little different here. You have less than 30, 30 to 35, and greater than 35. But you can see that the rates are very high, greater than 70%, 72% for the youngest group. 30 to 35, we're still above 50%. And even for the older than 35, we're above 30%. Now you could carve this data up in different ways. This is just another way to look at it. This is looking at it based on whether the couple had normal fertility. So they were attempting to achieve pregnancy in less than 12 months. And the average time that it took for these patients to get pregnant was about 5 to 6 months. Okay, so greater than 70% in that group. And then infertile is the group that had been attempting to conceive for 12 to 24 months, greater than 50%. And then prolonged is they were attempting to get pregnant for more than 2 years. And you can see here, again, there's not really the drop off. Of course, these aren't age groups, but you don't see a difference in the prolonged infertility compared to the 12 to 24 month infertility. Now, I sent some questions to the authors, and they were kind enough to share some additional data that wasn't part of the publication. And once again, you will have access to the summary of this data, but I did want to share a few things with you. First of all, several of the couples in the entire group had previously gone through infertility treatment. Some had surgery, some had medical treatment, and some actually attempted assisted reproductive technology. The pregnancy rate for those that had previously failed assisted reproductive technology was 32% in this group. Also, I mentioned that the data only reported pregnancy, not live birth. However, they were able to document live birth in about 70% of the pregnancies. They did find about a 13% miscarriage rate, and they lost some couples to follow up, so they didn't know what the outcome was of those pregnancies. So in fairness, you could subtract out the 13% here, and you would see that the pregnancy rate is still, for the normal fertility, 60%, and for the infertile groups, greater than 40%. And then finally, 85, I think this is very important data, 85% of the pregnancies were achieved with the Billings guidelines alone. So just using NFP, a well-defined NFP method, most of these pregnancies were achieved. About 10% of them needed some additional hormonal monitoring, and they used the Brown hormonal monitor for these. And then about 5.5% of them also needed fertility drugs. So, majority of couples will get pregnant using the Billings rules for achieving pregnancy alone. But when then should you refer the patient for treatment? Dr. Vigil has published that those guidelines are if the patient has 3 or more abnormal cycles in a year or 2 consecutive abnormal cycles. Now we can get into and do a whole talk on what abnormal cycles are. We have that talk. It's called the continuum. And however, Dr. Pilar, she defined a normal cycle as one where there is ovulation. It's between 24 and 38 days. So less than 24 days or greater than 38 days would be an abnormal cycle. And there had to be a normal luteal phase length, which she defined as between 11 and 17 days. So that's what she defined as a normal cycle. If it falls outside of that, these criteria apply. Now, this is when the woman is in a normal reproductive stage of her continuum. If she is in, say, coming out of breastfeeding, this may not apply. If she has just recently gone off of hormonal contraception, this may not apply. And of course, menarche and menopause, perimenopause. These, in that stage of the continuum, it is more normal to actually see these types of abnormalities. And then unlike the IVF field, where they want the couple to have been trying for at least 12 months, if the couple has 2 or 3 cycles of precisely timed intercourse with peak identified, and there's no pregnancy, it's probably a good idea to refer them to treatment. So the data I've presented demonstrate that natural family planning and restorative reproductive medicine are as good or better than assisted reproductive technology for achieving pregnancy. But is there ever a time or a type of infertility, where IVF is better? And I can think of two possibilities, and that's severe male factor and blocked fallopian tubes. Now, restorative reproductive methods can sometimes overcome these. And by the way, if we did more research in this area, we would probably find cures. But these things have been largely ignored for the last 40 years because of IVF. But nevertheless, there could be some very resistant situations where IVF would be more effective in this form of infertility. But should the decision to use IVF always be based solely on the chance of pregnancy? And there are other, as I pointed out, there are other considerations. There's the health of the woman, there's the health of the child, there's the financial and emotional cost to the couple, there's also the moral, ethical, and spiritual concerns for the individual as well as to society. And also there's a bonus when you're using natural family planning, restorative reproductive medicine. So first of all, not only are the results almost identical or slightly better in an NFP, restorative reproductive medicine, but there's also the possibility that you could diagnose, treat, and cure infertility. So not just that single pregnancy, they may be able to go on and have multiple pregnancies throughout the rest of their reproductive life. And then, as we know, the chart is also a biomarker for health of the woman. So, given these results, why is mainstream medicine continuing to take this approach? Why do they virtually ignore the information that is being presented through restorative reproductive medicine and NFP? Now, this is going to be a discussion topic. You will receive a link to Canvas platform that you'll be able to register for free, and then you'll be able to participate in a discussion with other people on this webinar, as well as get those resources that I mentioned to you. And Sue will be sending those out to everybody on the chat at the end of this talk. But I'd like to share some of my perspective on it. I believe what's going on is a form of belief perseverance. It's maintaining a belief despite new information that firmly contradicts it. But there's a twist here. The twist is that natural family planning has been around way before assisted reproductive technology was. So it's kind of a rejection of old information, although we continue to learn and research the benefits of NFP and restorative reproductive medicine. And in medicine, there is already a very vivid example of this. It's given a term. It's called the Semmelweis reflex. It's a metaphor for a reflex-like tendency to reject new evidence or new knowledge because it contradicts established norms, beliefs, or paradigms. And it was named after this gentleman, Dr. Ignaz Semmelweis. He was a Hungarian physician, practiced in Vienna General Hospital back in 1846, so over 150 years ago. See, at the time, death of the woman from childbed fever was quite high. And in fact, in the wards here, they were as high as 10 to 20%. So 10 to 20% of the women were dying from childbed fever. And Dr. Semmelweis recognized that the doctors' wards had 3 times the mortality rate as the midwives' wards. But the midwives' wards, where the death rate was somewhere around 4 or 5%, was still quite high compared to today's standards. However, he recognized a sanitation problem. And this was before the germ theory had really been accepted. And what he did was he proposed the washing of hands with chlorinated lime solution. Especially physicians after they got done doing teaching autopsies. Because what the physicians would do is go into these big theaters and they would do autopsies on corpses. And then without washing their hands and without changing their garments, they would go into the maternity wards and deliver babies. And for proposing this, Dr. Semmelweis was mocked, he was discredited, he was eventually committed to an insane asylum. And he died of septic shock after being severely beaten. Now there's another thing that was going on that makes me, it's reminiscent of what I think is going on in today's world with the rejection of NFP, is there was a lot of politics going on at the time. There was a lot of political turmoil. And in fact, a few years after this, there was the Hungarian Revolution and a war against the ruling class of Austria. So there were polarized sides. And I think that also contributed to the lack of acceptance of this data. And it wasn't until a few years later that germ theory was really proven, and many of his students actually were important in credited for that. So in conclusion, science and medicine should not be practiced in a vacuum, void of moral boundaries, because this results in disorder. Assisted reproductive technology is a disordered approach and creates other serious issues while trying to solve one. And natural family planning and restorative reproductive medicine is a more therapeutic approach to treatment of infertility. So Sue, I'm going to stop my share here. If you will please share that link to the